Okay, now we're going to be moving into the muscles. There are a lot of muscles, and they're all going to be in similar areas. We have a lot going on in a very small area of the body. Um, so I've broken these down into different compartments. So this first compartment is going to be considered the anterior compartment. When we're in anatomical position, this is we have all the muscles on our forearm that are going to affect the hand. We're going to talk about extrinsic muscles and intrinsic muscles. Extrinsic muscles are muscles that are located outside of a joint but have an effect on that joint. So for example, our primary finger flexors, the muscle bellies for those finger flexors are not in the hand, they're actually in the forearm. Intrinsic muscles are muscles that are going to be located in the joint that act on that specific joint. So actually in the palm of the hand, we'll have these little tiny muscles that are considered intrinsic hand muscles because they're working directly where they're at. So extrinsic, or we're going to focus on right now, at the end of this chapter, we get into the intrinsic hand muscles. So starting with this anterior compartment, then I go ahead and again break it down into 3 different layers. Again, there's a lot of muscles here, so if you take them kind of group by group, it's going to make things a lot easier. So starting with the superficial layer, we have the pronator teres, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. Now these are the muscle groups, or the muscles, that all have that common flexor tendon origin. These are the ones we talked about in the elbow chapter. When you put the heel of your hand on your medial epicondyle and your thumb and other 3 fingers, move down your arm. This is the superficial group. This is our common wrist flexor group. We didn't have to know the individuals in the last chapter. We do have to know them in this chapter. So those 4 muscles are going to be the most superficial compartment. When we look at this overall slide here, all the dark purple, those are going to be the nerve. They're all going to be innervated by the median nerve. If it's in red, then it's innervated by the ulnar nerve. So in the anterior compartment, all of the muscles are innervated by the median nerve except for the flexor carpi ulnaris and 2 parts of the flexor digitorum profundus. And again, I'll get to that one later on. So again, make this as easy as possible for you and think of it more strategically versus trying to memorize a ton of muscles that have no relationship. Try to form relationships. So in this superficial compartment, the flexor group is the pronator teres, flexor carpi radialis, palmaris longus, and the flexor carpi ulnaris. Then if we take that entire group off, the next muscle we're going to see is the flexor digitorum superficialis. It's going to be one of our finger flexors. Then if we take the superficialis off, then we're going to see the deep group, and the deep group is our flexor digitorum profundus, our flexor pollicis longus, and our pronator quadratus. And we've talked about the pronator quadratus, how it is very deep. Well, it's in the deep group. And this is all on the anterior side of the forearm. So going through this specifically, we've already talked about the pronator teres. It starts on the humeral head and part of the ulna and is going to cross the anterior part. This is going to be your thumb when you put your hand on your medial epicondyle. Its job is to basically do pronation, is the pronator teres. It will help with elbow flexion, and like the other slide said, it will also be the median nerve. And so what I was talking about, so these 4 muscles here are in the superficial compartment of the anterior forearm, and your pronator teres is going to be the thumb. The next muscles we talk about are the flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. So as they run down, you can actually palpate these. You can feel them. And in certain positions you can actually see them. So these are going to be very superficial tendons that you're going to be able to really see in the wrist. You're not going to really be able to differentiate anything up at the middle forearm and up at the elbow because all the muscle bellies join together, but the tendons you can definitely feel. So the next one then is the flexor carpi radialis. It's going to start with that common flexor tendon on the medial epicondyle, and then it's going to run down and it's going to insert on the bases of the second and third metacarpal. So your index and your middle finger are the bases of those. These muscles are going to have, generally they're going to have more than one action. Whatever joints that these muscles cross, they're going to have an effect on those joints. So because the flexor carpi radialis starts at the elbow, it really doesn't do much in the elbow, but it's going to shoot down basically, the middle to lateral part of the forearm. It's going to insert over here by the thumb, so it's obviously going to do wrist flexion. That's its primary job. But based on the angle of pull, if it contracts, it's also going to help pull the hand over into pronation because it's pulling at an angle. It's not going to be a main pronator, but it will help with pronation. And because of, again, the line of pull, it will also help with radial deviation once other muscles start that. Palmaris longus is a really tiny muscle. It's going to also have that common flexor tendon origin, and it's going to insert not into a bone, but we call it the palmar aponeurosis. So on the palm of your hand, you have obviously all the bones are deepest, and then we have the ligaments on top of the bones. Then we have tons of fascia, and we have a lot of fat in there. And mixed in with that fascia and fat is this palmar aponeurosis. And we've talked about aponeurosis before, that it's just a really thick tendon-like structure. So instead of the palmaris longus actually inserting into a bone, it inserts into this tendon-like structure. Because of where it crosses, it's basically kind of shooting straight down and it's going into the palm of the hand in the middle, so it's not going to have any real effect except for wrist flexion. And it's a really tiny muscle, so it's not very strong in general. This is also one that's absent in about 15% of the population. So if you want to know if you have one, you can do it a couple ways. You can basically do opposition, so touch your thumb to your pinky and do slight wrist flexion, and it should pop out. It's a very small tendon, but it should be pretty prominent, and it should pop out when you do that because it is more superficial. It's not going deep into the bone, so when you do that opposition with wrist flexion, it usually pops out. And here's just a closer picture of what that palmar aponeurosis looks like. It's just this very thick tissue on the palm of the hand with the palmaris longus shooting right down into it. And your other one was your flexicarpi ulnaris. This one is moving to the ulnar side. It's going to have obviously that common origin with the rest of the flexors, part of it on the humeral head, part of it on the ulna. The interesting thing about the flexor-carpi ulnaris is at its insertion point, it does insert into the base of the fifth metacarpal, so all the way down here. So here's your metacarpals. It's going to insert into the base of the fifth, but it's also going to hold that pisiform. The pisiform was the sesamoid bone, the carpal, that's a sesamoid bone, and the pisiform is actually sitting in the tendon of the flexor carpi ulnaris. And based on where it crosses, it will do wrist flexion, and it will also help with ulnar deviation. Okay, so that completed the superficial group. Now we're moving into that intermediate level, where if we took off all four of those superficial muscles, then we're going to see our flexor digitorum superficialis. It is more superficial than the profundus. It's a flexor digitorum. It will flex the fingers. These two finger flexors are actually really cool in the way that they work. But specifically here, the superficialis is going to have a little bit broader origin. It's going to have part of the on the humerus, then it's going to have part of the origin on the ulna, and it will also have some origin on the radius. So it does have that broad origin. It's going to head straight down, and if you actually look at some of these carpals, when we get the models out in lab and in class, the carpals, because the pisiform and the hook of the hamate are sticking out on this side, and the way that the triquetrum sticks out on this, or I'm sorry, the trapezium sticks out on this side, it actually forms kind of this tunnel, and it's gonna end up be calling the carpal tunnel, and because you have a bony prominence sticking up on this side, a bony prominence sticking up on this side, and then structures running through this tunnel. So this flexor digitorum superficialis actually is going to start off with one big muscle group, and then it's going to split into four separate tendons that are going to go to your four primary fingers. So not your thumb. Your thumb has its own muscles, so that the rest of the fingers are controlled by the superficialis. The other very cool thing about these is the insertion point. The superficialis does not go all the way to the distal phalanx. The superficialis actually splits and inserts at the base of the middle phalanx. So it does not have any effect. It does not go out to the distal phalanx. It does not cross that distal interphalangeal joint, and therefore it is not responsible for flexing this distal interphalangeal joint. So based on where it crosses, what is it going to do? It's going to help with wrist flexion. It crosses the metacarpal phalangeal joint, so it's going to help with this joint flexion, and it does cross the proximal interphalangeal joint, so it will help with proximal interphalangeal joint flexion. It does not go out to the distal phalangeal joint, so this muscle does not flex the last joint in the fingers. So if we take the superficialis off, now we have the profundus. So the superficialis and the profundus are going to work together. We have to have both of these muscles in order for us to have full flexion of all of our joints. So this one's not going to have as broad of an origin. It's going to be mostly on the ulna, but the insertion, again, is different. It's going to run right below the superficialis, and it's going to head straight to each of the 4 fingers. But unlike the superficialis, this one's going all the way to the base of the distal phalanx. So when we look at the actions, the profundus will do flexion of the wrist, it will do flexion of the metacarpal phalangeal joint, it will do flexion of the proximal interphalangeal joint, and it will do flexion of the distal interphalangeal joint. So this is the only muscle that is going to do flexion of that distal interphalangeal joint. So the profundus and the superficialis have to work together in order for us to have full finger motion. Like on the first slide that introduced these muscles, this profundus is going to actually have split innervations. The second and third slips of this are going to be innervated by the median nerve, and the fourth and fifth slips are going to be innervated by the ulnar nerve. So looking at these a little bit closer and how the superficialis and profundus work together, we talked about how the superficialis, it actually splits, so it's actually cut off in this picture. The superficialis is cut off, but it's going to split apart, and it's going to insert on each side of the base of the middle phalanx. And then we're going to have the profundus, which is what these tendons are going to be coming down to each finger, and they're going to actually go underneath the tunnel formed by the superficialis all the way to the distal phalanx. So the superficialis actually splits and forms a tunnel so that the profundus can come out and go all the way to the distal phalanx. And this is a picture I normally draw on the board, but the dark purple line is what my representation of what the superficialis looks like, where we have our metacarpal, our proximal phalanx, our middle phalanx, and our distal phalanx. The superficialis is going to be on top. It's more superficial. It's going to split, and it's going to insert into the base of the middle phalanx. And then we have the yellow is going to be the profundus, where it just shoots straight down. It's going to be deeper, so it just continues all the way down to the base of the distal phalanx. Again, it's really important to understand that the superficialis does not go to the distal phalanx and will not do flexion of that distal interphalangeal joint. Here's another picture of it, more anatomical than my drawing. And they have these structures actually pulled up. So in this case, here is our superficialis, where it's shooting down, and here it's splitting, and it's moving into each side of the base of the middle phalanx. Then we have our profundus lying directly under it, where it's going all the way down to the distal phalanx. I like this picture. Okay, and then also in the deep category here, we have our flexor pollicis longus. Whenever you see pollicis, or pollicus, however you want to say it, we're talking about the thumb. So in this case, this is going to be our primary thumb flexor. We'll also see brevises. Whenever you see longus, there is generally a brevis with it as well. The longus is generally longer. In this case, it's going to start, the origin is going to be along the radius. It is also going to run in that tunnel formed by the trapezium and the pisiform. So it's going to actually run around this tunnel, and the way it's going to orient itself, kind of hook in here and be held in place by the bone, and then it's going to run on the palmar side all the way out to the distal phalanx. So this flexor pollicis longus is actually going to cause flexion. It might help with some wrist flexion. It will do carpometacarpal joint flexion. It'll be metacarpal phalangeal joint flexion, and it will result in interphalangeal joint flexion. This is our primary thumb flexor. And we've already talked about the pronator quadratus. It does pronation. It's very deep. It's very distal. It's sitting right on top of the interosseous membrane. Alright, so then the next group now is the posterior compartment. So all on the back side of the forearm. These again are all extrinsic muscles. They're all going to start on the outside and end in the hand. They're all going to have an effect on the wrist and hand. So I broke these down into superficial, deep, and there's a separate group called outcropping muscles. These are going to be muscles that are going to affect basically just the thumb, but they're going to kind of be positioned by themselves. So the superficial muscles are the brachioradialis. We've already talked about that one. Your extensor carpi radialis longus. And then we have a group of our common extensors, which I mentioned these. So we talked about the common wrist extensor group at the elbow. Here are the specifics: extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi. And whenever we see digiti minimi, we're always talking about the pinky, and extensor carpi ulnaris. Our deep ones are going to be supinator and our extensor indices, and then our outcropping are going to be all of our thumb muscles that are going to be on the posterior side of the arm. Brachioradialis, we've already talked about. It's going to start up in that supracondylar ridge, and it's going to insert at the styloid process of the radius. It is not going to cross the wrist, so it's not, besides its location, we're not going to talk about it all that much. But it does do supination and pronation, but it's not really going to affect the forearm, or it's not going to affect the wrist, fingers, or hand. All of these posterior muscles are all innervated by the radial nerve, so that makes it easy for you. If it's on the posterior side, it's the radial nerve. So then we're looking at the extensor carpi radialis longus. This one's going to be a little bit longer than the brevis. So your extensor carpi radialis longus is going to start up higher on the supracondylar ridge than the brevis is going to. It's going to go all the way down the radius, and this is the posterior side, so it's going to insert on the dorsal surface of the hand at the base of the second metacarpal. So it's going to shoot straight down. Based on where it's located, it will obviously do wrist extension, but it will also help with radial deviation. For your extensor carpi radialis brevis, like I said, the longus started up higher on the humerus. The brevis is a little bit shorter. It's going to start on the lateral epicondyle, and it's going to also basically follow the same path, but it's going to insert into the base of the third metacarpal on the dorsal side versus the second metacarpal. So the radialis longus inserted over here, the brevis inserts over here. But it's going to have the same actions. It's going to run right with it, so it will do wrist extension and will help with radial deviation. Your extensor carpi ulnaris is also going to have that same origin at the lateral epicondyle with the common wrist extensor group. It's going to go down to the ulna side, so it's going to insert onto the base of the fifth metacarpal, and it's going to obviously do wrist extension and will also help with ulnar deviation. Your extensor digitorum is going to have that common origin on the lateral epicondyle. It's going to go directly down the posterior side of your arm, and like your flexor digitorums, we only have one finger extensor. So unlike your flexors, we only have one finger extensor, one muscle. But like the flexors, it is going to split off into 4 different slips, and it's going to go down to each individual finger. This one is interesting because the insertion is a little bit different. So like I just talked about how the superficialis, it actually splits at the proximal phalanx, the flexor digitorum superficialis actually splits, and it's going to insert into the base of that middle phalanx, and the profundus is going to go through all the way to the distal phalanx. So it's going to take 2 muscles to flex all the finger joints. The extensors are only going to have one muscle to extend all joints in the fingers. So all the interphalangeal joints and the metacarpal phalangeal joints are going to be extended by just the extensor digitorum. But the insertions are relatively complex. So if we look at this picture, it's basically the opposite of what the superficialis and profundus are doing. So here's one of our extensor tendons coming all the way down, and within one muscle, it's going to have one slip that actually inserts directly into the base of this middle phalanx, and then within the same tendon, we're going to have offshoots that come around that insert into the base of the distal phalanx. So, let's see if I can draw on this. It's coming down, and one part is going to insert here at the base of the middle phalanx. And then we're going to have within the same muscle, the same tendon, it just offshoots here, and it's going to go around, and then it's going to insert into that the base of the distal phalanx. So where on the flexor side it took 2 muscles to flex all the joints, in the extensor group it's only going to take 1 muscle in a relatively complex insertion to extend all the joints. So all this working together, the digitorum will extend the wrist, extend the metacarpal phalangeal joints, extend each of the individual interphalangeal joints, both proximal and distal. And then, like I said before, the extensor digiti minimi, whenever you see the digiti minimi, it's always going to mean pinky. It's interesting that they're going to be your pinky and your index finger, and your thumb is obviously a different story, but your pinky and your index finger are going to have specific muscles that are going to help them move. We have a lot more motion, an independent motion, with our pinky and with our index finger. And that is because they have individual muscles that are assigned just to those fingers. So our extensor digiti minimi is an extensor muscle that's going to allow independent motion of the pinky. Because we have the extensor digitorum, the one muscle that's responsible for extension of all four fingers. But when that muscle contracts, it's really not allowing for us to have a lot of independent motion. So we are able to extend our pinky without having to extend the other four fingers, because the extensor digiti minimi is allowing that to happen. It's going to be part of this common origin at the lateral epicondyle, and it is going to travel, and it actually runs into and joins the tendon of the extensor digitorum. So it's going to work together. So it basically just steals a tendon. So we have a muscle here, and as it becomes a tendon, it's going to actually join up with the common extensor digitorum that's going to that pinky. So the pictures on the next slide will show you. But it's not its own individual tendon. It actually just joins up with the tendon from the extensor digitorum. Based on where it's at, it's going to help with wrist extension, but it's also going to do extension of the carpometacarpal joint, the metacarpal phalangeal joint, and the both interphalangeal joints. So here's what I'm talking about. Here is the tendon of the extensor digiti minimi, and it actually is going to end up joining up with the rest of the tendon. So in this picture, it kind of looks like two separate ones, but in reality, this is going to basically fuse together, and the common tendon from the extensor digitorum is going to join with the extensor digiti minimi. Supinator we've already talked about. It's going to start on the lateral side epicondyle and radius, and ulna, and it's going to wrap around the radius and cause supination. Okay, so then we have these outcropping muscles, and I'm not really sure why they're really called outcropping muscles, but they're going to affect the thumb. They're going to be all grouped together. They're going to be located on the posterior side, because we're on the posterior compartment here, and they're all going to affect the thumb and or index finger. So we're going to have the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus. And if we look at this, these are the muscles that are really going to be forming the anatomical snuff box as well. The extensor pollicis longus and abductor pollicis longus and the extensor pollicis brevis are going to be the ones that are going to go toward the thumb, that actually form the anatomical snuff box, and that's where we're going to find the scaphoid. The extensor indicis is not going to the thumb. It is actually going to the index finger. So like I just said, how the extensor digiti minimi allows for independent extension of the pinky, the extensor indicis is going to allow for independent motion extension of the index finger. So we're able to have a lot of independent motion with our index finger, our second finger, because the extensor indicis is going to allow us to move that without having to contract the entire extensor digitorum. So starting with that one, it allows for independent second digit extension. So it's not a very large muscle. It is going to originate down further on the ulna. This is the posterior side, remember that. And it's going to insert into that extensor digitorum. So around the middle phalanx here, it's going to actually, just like the digiti minimi did, the extensor indicis is going to actually join up here. So when it pulls, it actually takes over this tendon and allows for that independent movement. That's the biggest thing here. We have a lot of motion with our index finger and with our pinky, but we don't have a lot of motion with our third and fourth finger. Actually, if you were to make an entire fist and kept your knuckles fully flexed, your MCP joint fully flexed, and you try to totally extend your middle finger or totally extend your ring finger, you can't do it. You can do both together, but you're not able to extend one all the way without extending the other. That's because your ring finger and your middle finger don't have separate muscles that work with them. Where if your MCP joint was fully flexed, you can fully extend your index finger and you can fully extend your pinky. But you are not able to fully extend your middle finger when the rest of your fingers are flexed. That is because your third and fourth fingers do not have any other muscles working with them except for the common extensor digitorum. Okay, so then moving on to the thumb then, the abductor pollicis longus, this is going to be longer, and it's going to cause thumb abduction. So when you, these muscles, again, the names kind of run together, but if we kind of sound these out and really kind of figure out where they're at, abductor pollicis longus is going to abduct the thumb. So it's going to have to sit a little bit more lateral because muscles are only going to pull. They do not push. So they have to be positioned in a way where they can pull into abduction. So it's going to start up on the ulna again, but it's going to insert on the radial or lateral side of the base of the first metacarpal. So it's going to run up to the base of the first metacarpal, and it's going to have an effect on abduction at that joint, so the first metacarpal joint. So its action is abduction of the first carpometacarpal joint, and based on its positioning, it will also help with extension and radial deviation, but its primary job is abduction of the carpometacarpal joint. And again, that's going to be down here. Our abductor pollicis longus is inserting at the base of the first metacarpal all the way down at basically the anatomical snuff box. Then you're going to see your extensor pollicis brevis. The brevis is going to be shorter than the longus. So our extensor pollicis brevis is going to be positioned right next to the abductor pollicis, but it's going to come down and it's going to basically insert into the base of the proximal phalanx. Based on where it's moving, it will affect the carpometacarpal joint, and it will help with extension of the metacarpal phalangeal joint. Because it does not run out here, the extensor pollicis brevis will not help with extension of the interphalangeal joint. For that, we're going to have to use the extensor pollicis longus. The extensor pollicis longus is going to form the more medial part of the anatomical snuff box, and it's going to run all the way out to the distal phalanx. So it will cause extension of the carpometacarpal joint, the metacarpal phalangeal joint, and the interphalangeal joint. So again, if you can visualize where these things run, you should know what action they're going to do. Okay, and now moving into the intrinsic hand muscles. These are, again, the small muscles that are going to be located within the joint that they're affecting. Where all the muscles we talked about so far started outside of the joint in the forearm and affected different joints like the wrist and the hand joints. These are going to be the tiny muscles found actually in the palm of the hand. So we have two areas of the hand that we talk about. The first one is going to be the thenar eminence. This is going to be the muscle mass found around the thumb. So it's going to be on the thumb side. The thenar eminence is composed of several muscles. The ones I want you to know are the flexor pollicis brevis. That one is going, again, how it's positioned, it's going to be in the location where it can cause thumb flexion. Abductor pollicis brevis, where it's small, is going to help with abduction. And then opponens pollicis is kind of located at an angle so that it will help that opposition. We also have this big chunk of muscle here in the middle, kind of in the web space, and that is your adductor pollicis. Although the flexor pollicis longus is an extrinsic muscle, it's also going to run right up here and along the thumb, and it's actually cut right here. So that's going to be your flexor pollicis longus. It's going to be in that area. When we look at the hand and the hand innervation, basically the hand is split into into halves. Your pinky and ring finger are going to be one half of your hand, and then your thumb, index finger, and middle finger are the other half of your hand. Generally speaking, your pinky and ring finger are going to be innervated by the ulnar nerve, and then your thumb, index finger, and middle finger are going to be innervated by the median nerve. In this case, those do follow the rules where these three muscles are innervated by the median nerve. The adductor pollicis, like I talked about, this muscle right here, is actually innervated by the ulnar nerve. So I don't know why it doesn't follow the rules, but that is one that is the ulnar nerve, even though it's on the medial side. So the thumb side was the thenar eminence. Now the other massive muscle we're going to talk about is going to be on the opposite side, the pinky side, and this is going to be considered your hypothenar eminence. So it's this muscle groups over here is your hypothenar. These are all innervated by the ulnar nerve, so they do follow the rules because they're on the ulnar side of the hand. And this is going to be your flexor digiti minimi, and your opponent's digiti minimi, and your abductor digiti minimi. They're all digiti minimis. They're all going to affect the pinky. For the muscles in the thenar eminence and the hypothenar eminence, I want you to know, which muscles are which based on where they're at, but you do not have to memorize origin, insertion, and action. I do want you to know innervation, so know which muscles are in which eminence, and know their innervation, but you don't have to specifically know origin and insertion. Here's just a different picture to help you kind of visualize what's going on here, of the different muscles that we just talked about in the thenar and the hypothenar eminence. And then we have our palmar and dorsal interossei muscles. These muscles are going to help us with abduction and adduction of our fingers. And it's easiest to remember DAB and PAD. So DAB are going to be our dorsal abductors. They're located on the dorsal side of the hand, so the back side of the hand, and they're responsible for abduction. So you can see the positioning here. They're going to run basically in between the metacarpals. They're positioned more dorsally, but they're going to be located in between them, and they're going to insert in a spot where they can cause abduction. The fifth metacarpal, the fifth finger, does not have its own dorsal abductor because it has its own abductor digiti minimi. So we don't need this DAB muscle because it's got its own official one assigned, because it's the abductor digiti minimi. So we don't need one. So we can still do abduction of the fifth finger, just not with a DAB muscle with its own specific digiti minimi. So if you look at these muscles and how they're positioned, because muscles are only going to pull, if I give you a picture and ask you which muscle was this pad or dab, you should be able to figure it out because muscles are only going to pull. So it's going to pull this fourth finger into abduction. The middle finger gets both muscles, both the 2 and the 3, because it can go abduction in both ways. And then the first finger will have another dorsal abductor. Look on the palmar side, these are PAD, palmar adductors. So these muscles are all positioned where they can adduct the fingers back into the neutral position. Because the third finger has 2 abductors, it doesn't need any adductors, because if the finger was abducted over here, the other dorsal abductor would pull it back. So the third finger does not have any adductors, but it has 2 abductors. And I think the last one we're going to talk about here is the lumbricals. I know you can't see that, but this says lumbricals. These are muscles that are all going to originate. They're really tiny muscles. They're going to be located on the palmar side of the hand, and they're going to actually have an origin on a tendon. So here's our flexor digitorum profundus. The profundus, again, moves into 4 slips, and it's going to travel underneath the superficialis all the way out to the distal phalanx. The lumbricals, each one, is going to originate on the tendon. So it does not have a bony origin. It originates on a tendon. And these are going to be really interesting because they're going to start on the palmar side. So all the origin of the lumbricals, there's 4 lumbricals, they're going to start on the palmar side. But as they move, they're going to actually move and insert on the dorsal side of the phalange. So they're starting on the palmar side, but they're going to cross over the joint and they're going to actually insert on the dorsal side. So the action of these lumbricals really is what we call the Z movement, and I found this picture because when these muscles contract, they're going to cause flexion of the metacarpal phalangeal joint because they're on the palmar side. As they cross the metacarpal phalangeal joint, they're still located anterior to that joint. So it's going to help with flexion of the metacarpal phalangeal joint. But as they cross that metacarpal phalangeal joint and keep on moving, they actually insert into what we'll call the extensor hood, which I'll talk about more in a second. but they're going to actually join up with the extensor tendons on the dorsal side of the hand. So although they're going to do flexion at the metacarpophalangeal joint because they start on the anterior side, they move posterior, so they're actually going to do extension of the proximal and distal interphalangeal joints. So the lumbricals, the action actually looks like this, and it's a Z movement because it's Z. So if his arm was up here, that would create our Z. But really, right here, flexion of the MCP and extension of the PIP and DIP. So these are really interesting muscles. So looking at this and understanding how this works and how the extensor, digitorum, and the lumbricals kind of all work together. So what we have here is we talked about the extensor digitorum and how the extensor digitorum, it comes down and it's all one big tendon, and then it's going and it's going to keep on going, and it's going to have one insertion into the base of the middle phalanx, and then it's going to actually just have fibers split off that run around the side, and they're going to come back to the back and insert into the distal phalanx. This whole thing is called the extensor hood, and it's a pretty complex situation. And then when you add the lumbricals into it, the lumbricals are going to help with this even more. So the lumbricals are going to be coming around from the remember they start on the anterior side, and as they cross the metacarpophalangeal joint, they're going to actually join up with this rest of the extensor hood. So we have all this tissue on the back, all kind of working together. But your extensor digitorum is going to have one insertion into the base of the middle phalanx, and then it's going to split around. This setup is going to be really important in order for us to understand different injuries that we see, because if we rupture a part of this hood, we're going to get specific types of deformities. So understanding how this all works together is important. And because the lumbricals actually join up with the extensor hood, that's why they do extension of the PIP and DIP, but they do flexion of the metacarpophalangeal joint. So let me get rid of all this. So looking at it again here, we have to look at the center of rotation. So each one of these joints is going to have a center of rotation. So here's our metacarpophalangeal joint, our proximal interphalangeal joint, and our distal interphalangeal joint. So based on this, obviously the extensor digitorum is going to come back here. It's behind the joint, so it's going to cause extension. Because it's going to continue on, and it's going to be behind here, it's also going to cause extension. Because these two slips come around each side and is also behind the joint, it's also going to cause extension. So obviously, the extensor digitorum is going to cause extension of all the joints. That's a pretty obvious one. However, now we can look at the lumbricals. The lumbricals are going to be located anterior to the center of rotation at the MCP joint. So it's going to actually cause flexion of the MCP. But then as they join up with the extensor hood, now they're going to follow these two rules, which is why, again, it does that Z movement where it's flexion of the MCP and extension of the PIP and the DIP. Alright, so then we have, I mentioned this carpal tunnel idea when we talked about the superficialis and profundus. If we look at this picture right here, we're looking at the palmar aspect of the wrist. And here are the bones that are going to help form the basically this tunnel. So we have our carpal bones, and we're going to have on the ulnar side, we're going to have our pisiform and the hook of the hamate, and then on the medial side, we're going to have the trapezium that articulates with the thumb. And they're positioned so that there is an angle like this. So we have this nice little groove for the carpal tunnel to sit in. There are 10 structures that actually run through this carpal tunnel. And you're going to have to know all those 10 structures. The flexor digitorum superficialis has 4 tendons, so there's 4 right there. The flexor digitorum profundus also has 4 tendons, so there's 4 more, so that's 8. Then we have our flexor pollicis longus that's going to run around the that trapezium up into the thumb, so that's number 9, and our median nerve is number 10. So the 10 things that are going to be in the carpal tunnel are the 4 superficialis tendons, the 4 profundus tendons, the flexor pollicis longus tendon, and the median nerve. So because this is a tunnel, it's going to have a floor, it's going to have walls, and it's going to have a roof. The floor and walls are going to be formed by the carpal bones, and then we have this transverse carpal ligament that actually forms the roof. So there is very little room in this area for any swelling to occur. So when people get carpal tunnel, and we'll talk about this more, but repeated finger flexion with your wrist and extension is going to put a lot of stress on that carpal tunnel because your finger flexion, so like when you're typing, your wrists are extended and your fingers are constantly flexing and moving. It could be irritating in here. Irritation means inflammation, which is swelling, which is going to put pressure on the median nerve, giving you those neurological symptoms. Okay, then we have our anatomical snuff box. We've mentioned this before. The anatomical snuff box is an important location in the wrist because it is where we can easily palpate the scaphoid bone. The scaphoid is the most commonly fractured carpal bone. So when someone has pain with palpation in the anatomical snuff box, there is oftentimes a scaphoid fracture. Also in there, we will see part of the radial artery running through. And the actual snuff box itself is formed by those outcropping muscles, your abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus. So it's kind of hard to see in this picture, but here is the snuff box a little bit closer, so this is what it looks like. We have our extensor pollicis longus here. We're going to have our extensor pollicis brevis here, and then our abductor pollicis. We can't really see all that much because it's going to insert very deep to the base of that first metacarpal, so we don't see it because it's actually inserting. It's running right here, right next to the extensor pollicis brevis, but it's going to insert all the way down here, so we really can't see it all that often. But you can definitely feel it when you move your thumb around. So the snuff box is the actual middle part here. Here's your extensor pollicis longus, and it's going to be the one running all the way up to here. Let's see if I can drill it on. And then your extensor pollicis brevis is going to be moving right into there, and your abductor pollicis is going to be right next to it. So that's what the anatomical snuff box looks like. Very easily seen when they do any kind of thumb abduction or extension.